Good morning, everybody. I would like to introduce Josh Kapp. Josh is a fifth-year resident in our department, and he has prepared a talk about the surgical treatment of gastroduodenal ulcer disease.
Thank you very much for the introduction. Good morning, everyone, and welcome to this morning's talk on the surgical management of peptic ulcer disease. Today I'm going to talk to you about the definition of what a peptic ulcer is, a little bit about the epidemiology, etiology, a little physiology, talk about the important anatomy, presentation and workup of this disease, what the indications for surgery are, and an overview of some of the various surgical techniques, and then some important take-home messages. So gastric ulcers and duodenal ulcers used to be some of the most commonest indications for gastric surgery. Today, however, elective surgery for this disease is very unusual, less common, and this is thanks to two things: the successful development of anti-acid medication and eradication of Helicobacter pylori. Complications of peptic ulcer disease do, however, still occur, and when this does occur, surgical management plays an important role. And here we see an example of gastric erosions and a big gastric ulcer. The definition of peptic ulcer disease comes from the Greek peptikos, which means able to digest. And the definition of an ulcer is a break in the gastric mucosa extending beyond the muscularis propria, which is this level here, and a break larger than 5 millimeters in diameter. An erosion, on the other hand, is simply an interruption of the gastric mucosa that does not extend beyond the muscularis mucosa. What does the epidemiology look like? It affects 4 million people worldwide, an incidence of 1.5 to 3% in developing countries. There is a lifetime prevalence of perforation of peptic ulcer disease of about 5%. Mortality of perforation can be very high, up to a fifth of patients, with 30 and 90-day mortality at 20 to 30% respectively. As mentioned, the advent of anti-acid medication and Helicobacter pylori treatment has, however, over the years significantly reduced complications or peptic ulcer disease in US hospital admissions. This shows hospital admissions of gastric ulcers and duodenal ulcers from 1993 to 2006 have gone down about 20 to 30%. Risk factors for peptic ulcer disease. There are a few different ones, the most important being Helicobacter pylori. We'll talk more about that, and medications such as non-steroidal anti-inflammatory drugs and steroids. Lifestyle risk factors such as smoking and alcohol, malignancy, and states of extreme stress. So when peptic ulcer diseases occur, in the case of head injury, neurosurgical cases, these are often referred to eponymously as Cushing's ulcers, and in states of extensive burns and stress associated with that, Curling's ulcers. Helicobacter pylori was discovered by Dr. Robin Warren and Barry Marshall. They both won the Nobel Prize for Medicine in 2005 for their discoveries. And Robin Warren was a pathologist in both doctors working in Perth, Australia. Robin Warren was a pathologist and Barry Marshall was a clinical fellow. And they were the first to correlate biopsy findings, the presence of Helicobacter microbes in states of gastritis and peptic ulcer disease. And then this poor chap decided that he was going to prove this then by swallowing a nice cup of Helicobacter, developed a nasty case of gastritis, and then ended up treating himself for that. So perhaps Robin Warren wasn't the nicest boss to have around. Who knows what things are like in Australia. Helicobacter pylori is a gram-negative rod. It looks like this. It's present in up to 50% of the entire world's population, so it's extremely prevalent. It's transmitted through vomit, stool, or saliva, infected, of course. And it was previously thought to also come from infected water sources and infected food. However, this has recently been proven to be controversial. Although DNA can be detected in these sources, microbes cannot be cultured in most cases, so this is probably less likely. And here, this shows you really how important this infection is to peptic ulcer disease. It's associated in 95% of duodenal ulcers and 70% of gastric ulcers. And H. pylori has some interesting mechanisms that it uses to contribute to the development of ulcer formation. Firstly, it has these neat flagella here, which allows it to travel from the gastric lumen down to the gastric epithelium. Secondly, it has an enzyme called urease, which allows it to convert urea and water into ammonia and carbon dioxide. And ammonia, being alkali, helps it form a protective mechanism to withstand the extremely acidic pH of the stomach. Then, using these polyliposaccharides, it's also helps it adhere to the gastric epithelium, and then it has two main endotoxins, VAC-A and CAG-A, both of which contribute to cell lysis, cell apoptosis, inflammatory cascade activation, and disruption of cell integrity by breaking the tight junctions which join the gastric epithelium together. This is how gastric ulcers are then created or caused by this infection. And in addition, it causes an inflammatory cascade producing interleukin-8 secretion, as well as histamine production, which then goes on to activate gastric parietal cells and increase gastric acid production, causing a vicious cycle and making the ulcer worse. How do you diagnose Helicobacter? There are various diagnostic tests which can be categorized into invasive and non-invasive tests. The best invasive tests, which are performed during endoscopy, are the Campylobacter-like organism test and PCR test. They have the best sensitivity and specificity and require a biopsy. And non-invasive tests, the carbon-13 breath test and stool test, are the most sensitive and specific. Treatment is a triple chemotherapy consisting of a high-dose proton pump inhibitor and 2 antibiotics. This would be appropriate for a patient who's penicillin allergic, for example. The treatment needs to be given for 7 to 14 days. All patients with peptic ulcer disease need to be tested and treated for H. pylori if the test is positive. Patients should be retested 4 weeks after treatment and no sooner because of the risk of negative test. And additionally, any patient being tested for H. pylori with or without ulcers should stop proton pump inhibitors at least 2 weeks before the test due to the risk of false negatives. Briefly about the mechanism of drug-induced ulcer disease. The key drugs at play here are non-steroidal anti-inflammatories and steroids. Steroids act here inhibiting phospholipase A2, NSAIDs inhibiting cyclooxygenase type 1 and 2, and at the end of the day, this results in reduced prostaglandin production. Prostaglandins are important for gastric mucosa production and bicarbonate production in the stomach, and this results in loss of gastric mucosa integrity. What is the important anatomy? It's important to recognize gastric ulcers usually occur here at the lesser curvature, where you have this complex vascular arcade coming from the left gastric artery. Duodenal ulcers are 4 times more common than gastric ulcers, and they usually arise in the first part of the duodenum. And so it's important to have an appreciation of the gastroduodenal artery here and the pancreaticoduodenal arteries. This gives you a little close-up of the delicate structures involved here, including the porta gastroduodenal artery and the bile ducts. So this is a dangerous place to work, and you really need to have a plan and know what you're going into beforehand if you're operating. A quick overview of the physiology. This is more relevant for the historical surgical treatment of the disease because the gastric G cells, which produce gastrin, an important trigger for acids production in the parietal cells, is mainly located in the antrum. And for this reason, historically, antrectomy with or without truncal vagotomy was a mainstay of surgical treatment. Nowadays, less so. I'll explain why later. And the gastric parietal cells are usually located, or mostly located, in the corpus. And then here you see the interplay of vagus nerve stimulation causing acetylcholine, D cell activation, somatostatin, activation of the enterochromaffin-like cells, which then secrete histamine, which activate the parietal cell acid production. How does peptic ulcer disease present? Well, usually with epigastric pain. In the case of duodenal ulcers, pain usually occurs before meals and at night and is relieved by eating. Paradoxically, gastric ulcers are worse on eating. Patients develop food fear and therethrough weight loss, and this pain is usually relieved by antacids. If perforation occurs, this results in usually acute sudden upset, abdominal pain, peritonism, and board-like rigidity of the abdomen. Some important points of the diagnostic workup: blood tests looking at hemoglobin, full blood count. Urea can be a useful tool because it goes up if blood has been digested in the stomach. Carbon-13 breath tests can be performed electively during if the patient is not presenting acutely. Diagnostics really involve plain films, which are often negative, looking for free air under the diaphragm, CT, which is not always sensitive, and endoscopy, which is the gold standard, with H.pylori test and biopsy to check for malignancy. 5% of all peptic ulcers can be malignant, and gastric levels of Soliger-Ellison are suspected. There is a classification for gastric ulcers, which is according to the location. So type 1 is located in the corpus, usually along the left curvature. These are the most common. Type 2 refers to 2 ulcers, one in the duodenum, one in the gastric body. Type 3 are pre-pyloric ulcers, less common. And type 4, these are really difficult to treat surgically, the high-riding ulcers near the lower esophageal sphincter. I'm going to focus on the 2 commonest complications of peptic ulcer disease in terms of surgical management: bleeding, which accounts for the vast majority of complications in 73%, and perforation. Other complications include obstruction, intractable disease, and suspected malignancy. And another comment on how the overall prevalence of this has reduced over the years: this graph shows presentations of peptic ulcer hemorrhage in the US between 1993 and 2006 has gone down again about 30%. And so this can be challenging for surgeons to deal with when it comes, because not a lot of cases do present and it's hard to build up the experience. The indications for surgery are fourfold according to the American Society of Gastroenterologists: failed endoscopic therapy, hemodynamic instability despite volume resuscitation exceeding 3 units, recurrent hemorrhage after 2 attempts at endoscopic treatment, and continued slow bleeding requiring more than 3 units a day. My question: does anyone know some good risk stratification tools to assess how severe an upper GI bleed may be?
I think there are 2 risk scores. One is the ROC-ALL score, where you can check the risk for rebleeding. And the other one is the Glasgow-Blatchford score, where you have the risk of endoscopic intervention. Absolutely.
Thank you for that. So this gives you an overview of the criteria for the Blatchford score. A score less than 3 has a chance of less than 6% for requiring intervention. A score greater than 6 gives you a 50% chance of requiring intervention, and a score carrying more than 8 gives you a high chance of requiring admission to an intensive care unit. And then the ROC-ALL score, as Dr. Müller said, can help you stratify the risk of rebleeding. So based on these criteria, a score of 3 or less has a rebleeding risk of 11% and a mortality rate of less than 5%, whereas a score of 5 or more has a rebleeding rate of approximately 25% and a mortality rate of greater than 10%. There are more useful classifications. Anyone know how to potentially classify a bleed and what the name of this classification is? And maybe you could help us classify this bleed here.
The relevant classification is the Forest classification. This would probably be a type 1, A or B.
Excellent. Absolutely right. 1A, ulcer with active pulsating bleeding. We can imagine that this would be pulsing quite nicely. And the utility of this score is it helps you understand what the risk of rebleeding would be. So in this case, 55%. Moving on to treatment. So where you've failed in your endoscopic attempt, you've had one or usually 2 attempts, and now you need to escalate your treatment. Do you operate or do you attempt embolization with your friendly interventional radiologist? Well, in most cases, embolization is an appropriate next step. However, surgery and embolization are equally effective following failed endoscopy. Embolization is particularly effective for patients who are unfit for surgery. And surgery is the best course of treatment for patients with a severe coagulopathy. At the end of the day, as usual, surgery if all else fails. And here shows an example in the case of a duodenal bleeding ulcer, how you can nicely embolize the gastroduodenal artery and also the posterior superior pancreatico-duodenal artery and anterior superior. And there's a nice photo there. 3 objectives of surgical management are hemorrhage control, historically surgical acid reduction, now this is done medically, and importantly, the approach to surgery is determined by the location of the ulcer, so it's useful to attend the endoscopy if you can. Surgical management of bleeding duodenal ulcers. So in the case of posterior bleeding ulcers, exposure is achieved using a duodenotomy or duodenopyloromyotomy. Then either the bleeding can be stopped by direct suture ligation. Often this will also require ligation of the gastroduodenal artery, and this can be reinforced with an omental patch. And this shows nicely how a longitudinal incision is made, but the closure is then done horizontally. In terms of surgical management for bleeding of gastric ulcers, there are various different techniques. That's the main take-home message here. If the ulcer is located along the larger curvature, then a simple wedge resection is usually achievable. If the ulcer is lower down, then a distal gastrectomy may be required, and this can be reconstructed with either a Billroth 1-2 or Roux-en-Y reconstruction. And for the high-lying ulcers, these are, as mentioned, difficult to treat and usually require a 2/3 gastrectomy or a subtotal gastrectomy, and then can be reconstructed with a Roux-en-Y. Moving on to perforation, the second main complication. Non-operative treatment can be successful in patients with duodenal or gastric ulcer perforation, but the patients need to be stable. 40 to 80% may seal off without surgery. Conservative treatment comprises bowel rest, nasogastric tube, and intravenous antibiotics. The patients absolutely need to have a diagnostic where either air or contrast medium is introduced to rule out extraluminal leakage. So this is only relevant for small perforations, but this has been demonstrated in a randomized prospective controlled trial published in the New England Journal of Medicine, which demonstrated 70% success in well-selected patients receiving conservative treatment. Operative treatment can then be pursued either with an open or laparoscopic approach. Laparoscopy is absolutely not appropriate for unstable patient. Second take-home message: if the patient is sick, they need an open a laparotomy. But the advantage of laparoscopy is that it has reduced surgical site infection, reduced incisional hernia risk, and reduced length of stay. And this has been demonstrated in several meta-analyses, in particular this Cochrane review here showing reduced overall mortality as well as these additional benefits when laparoscopic approach is used. There is another classification which can help determine how sick your patient is, called the Bowie score. It's simple. There are 3 factors: severe comorbidity, 1 point; preoperative shock, so systolic pressure under 90, 2nd point; and 3rd point, duration of perforation over 24 hours. And this can help you roughly stratify your morbidity. So anyone with 2 or 3, absolutely not a candidate for a laparoscopic procedure. In the case of gastroduodenal ulcer perforation, again, as mentioned, this can be closed either with a primary closure. There are some different fancy names for using a mental patch, so primary closure with a mental pedicle flap. Here, the so-called Kellen-Jones repair. Either this can be done by bringing up a pedicle of omentum or just a simple patch cut off and then sutured over. And the omentum can either be used to plug the hole or simply be sutured over the top. Now, we should mention that this diagram is not entirely accurate. Can anyone spot the mistake?
As you told us before, or showed us before, it's closed in the wrong direction. Like this, there's a risk of stenosis.
Excellent observation, yes. And in terms of treating perforated gastric ulcers, this slide just aims to show that there are a variety of surgical techniques. There are no strict recommendations. This depends on the operator experience. But at the end of the day, it's important to mention that a Roux-en-Y reconstruction will give you the flexibility you need in almost all cases. So you can either, for low-riding ulcers, you can perform a distal gastrectomy and then a Roux-en-Y reconstruction, or for high-riding, a more extensive gastrectomy with Roux-en-Y reconstruction. So that brings me to the end of my talk, and some important take-home messages is what I will leave you with. So duodenal ulcers are more common than gastric ulcers. H.pylori is a major risk factor. Patients with peptic ulcer disease require testing for this and treatment when positive. For bleeding, first-line treatment is endoscopy. Uncontrolled bleeding requires angioembolizational surgery. And for perforation, non-operative therapy is appropriate in selected patients, open surgery if unstable, and you can consider laparoscopic surgery in stable patients. Thank you very much for your attention.
Thank you for your talk. First, I want to mention that the non-operative treatment is afflicted with 30% with patients where it's not successful. You just mentioned the 70%, of course. And the second thing is, I have a question. If you have a bleeding disorder, you recommend to go for surgery instead for embolization, and why?
I think this has been drawn from the literature, isn't it? I know that usually in a bleeding disorder, it's also very risky to perform major surgery. And our first attempt will always be to perform endoscopy and to treat the bleeding via intervention, or even to ask our friends from diagnostic interventional radiology to help treating the bleeding via angiography. I think does not represent our access to those problems, and we first try to treat those patients conservatively. Thanks.
Just a question from my side. What is your experience, or what is the proposal you have for proton inhibitors for patients undergoing surgery? Should we give them to all of them, or is there any recommendation you found?
We do it in every patient, that's right, because we know that during surgery, if you have a high risk of complications with gastritis and also ulcer disease, maybe this is exaggerated. There are different opinions on that. I think it's an important question because it's also quite expensive to give every patient a proton pump inhibitor therapy. And there's a lot of debate around this topic. And honestly, I'm personally not sure what the best way is, whether to give prophylactic or not at all, or only in risk patients. I don't know the literature about this, to be honest.
Thank you for this nice talk. Resistance to medical treatment of HP, is this frequent or not?
I can't tell you the exact frequency, but it definitely is a problem. And there are several additional treatment regimens which can be used if there is resistance. And that's why it's important to retest. That's what's coming out of the German guidelines, that it's important to retest all patients after treatment 4 weeks afterwards to make sure that the eradication has been successful. Professor Gucci?
You can also, in persistent Helicobacter pylori infection, you can also sample the mucosa and take it to the microbiology department, and they do resistance testing on HP. And there are some salvage regimens that can be used to treat those patients. Thank you very much.
Thank you.